I'd like to welcome everyone. This is going to be a nice video clip associated with knee evaluation. Our subject is Jared, and I'll let him introduce himself.
Hello, my name is Jared, and I am a physical therapy student at UK here. About 6 weeks ago, I tore my ACL. I was playing church ball, and it was a non-contact incident. I was dribbling down the court. I wasn't shooting, I wasn't passing, I wasn't going up for a layup. I just stuck my right leg out to pivot as I was crossing the ball over to the left side of my body. And internal rotation, lateral translation of the knee there. Felt and heard a pop and collapsed, and I immediately knew that I had torn my ACL.
When Jared came in to see us a couple of days later, if you will, it was pretty obvious what we were going to be dealing with. So that's what we're going to be looking at. We're going to go through the sequence of the eval, and I think what you will appreciate is he's very thin, and it will be a very pronounced sequence for you. It'll be very clear. So to begin, we always start with the uninvolved extremity. So in this case, we're going to start with his uninvolved side, and what we'll do is we'll go back and forth. We'll go the uninvolved, demonstrate what we're going to do, and then go to the involved side and demonstrate, so that we're allowed to be able to be consistent. And if we ever have to do something twice, we would then be doing it twice on the uninvolved side rather than on the involved extremity. We'll begin with just the classic medial and lateral collaterals, and I'll have him on his back, and I'll get down in position. Doesn't matter. So, which extremity was injured? Thank you. I already knew that, but that's for positioning. Okay, I'm going to give you the microphone, and you can just hold it. What we're going to do first is we're just going to do medial and laterals. So we're going to do medial collateral and lateral collateral. And I'm going to show you a couple little tricks that I like to use. The first is the patient always has to have the head down. They've got to be relaxed. If they're trying to lift their head up and look, you can't do a very good assessment. So to begin with, make sure they go completely flat. You can put a pillow under their head if you'd like. But we want to make sure he stays relaxed. So I'm on the uninvolved side. So the initial and the first thing we're going to do is we're going to do medial laterals. The way we like to do this is you never want to go completely into hyperextension. The vast majority of people, when they hyperextend, and most people who do tear their cruciate in a non-contact format, like Jared did, do have some hyperextension. So never take them into full hyperextension for the assessment portion. What we're going to do is we go to their full range, and then we back down to where we're probably 3 to 5 degrees from full extension in a normal sense. And then we're going to do the second portion of the exam at approximately 20 to 30 degrees of knee flexion. Second thing you're going to notice when I do my assessment is I really want to make sure I get the end point. And so one of the really nice little tricks that you can use as you're getting ready to assess the medial side, for instance, we're going to put as much slack as possible into the medial side before we move in a lateral direction. So you'll see this here in a moment. So we go into his full extension position. We then come back from that to basically be just out of full extension. Support, this is the classic technique. I then apply the loading. Now the interesting part again is you can teach yourself to do this in a variety of ways. You can do it in this classic position. You can position using your elbow, stabilizing, and you can apply the load using your body, your hands. But the nice technique that I want to make sure that I get my classic assessment is I'm going to put him at rest and slack before we do the loading. And what you will notice is you get a very clear endpoint with him. We're then going to flex him approximately 20 to 30 degrees. Repeat. And since I'm in position, I'm going to go ahead and do the lateral side while I'm here. So, same technique. And you can see we get really nice endpoints by, again, putting him at slack before we accelerate. On the involved extremity, first thing you will notice is he doesn't hyperextend at the moment. And the reason for that is he's still getting rid of some of that swelling, that effusion that was generated. He's got a little puffiness, but not much. He's several weeks out, but he's getting ready to have surgery next week. In extension, in his case, I actually could go pretty close and then back off just slightly. And again, wonderful endpoints for the medial and lateral side. So he's fully intact, his collaterals are fine. Now, as classically taught, many individuals were initially taught to go into using the drawer test. Now, here's the thing about the drawer test. The drawer test is not as good as the Lachman for delineating an anterior cruciate injury, but we're going to have to do a drawer test to do the posterior cruciate. So one of the very nice things is that in individuals who are thin, as Jared is, a lot of times you may actually be able to get that endpoint very cleanly and actually have both the anterior and posterior assessments completed just using a drawer. The posterior cruciate drawer is typically done somewhere between 90 and 60. Stabilize the foot. Just as we did with the medial and laterals, if I'm going to do the posterior drawer, I'm going to pull him anteriorly before I apply the posterior loading. Now you can see I'm able to do this with Jared with one hand. That's not always able to be done, but in this case I can. But I will also then do it in the classic sense. Make the hamstrings lax, loose. There's his posterior cruciate. You can see very nicely. But his anterior cruciate, likewise, I am able to push him posteriorly and get a wonderful anterior endpoint. I think you can see that very clearly. So in his case, I don't have to do a classic Lachman because I've already assessed it on this side, but we'll demonstrate that in a moment. So the drawer test on the involved extremity, again, stabilize the foot so that we don't have internal external rotation different extremity to extremity. Hamstrings relaxed. I pull him anteriorly and then thunk him back. And Jared, you can tell them, you can almost hear it, let alone feel it. Thunk, thunk, thunk. And now anterior drawer, I push back. And he's got significant motion, but no thunk on the end. The term is he's thunkless, okay? And you can see very clearly, thunk, 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 and there's no thunk anteriorly. So the Lachman test is a more sensitive test because we don't have the hamstrings blocking. The Lachman test is literally doing an anterior drawer test at approximately 30 degrees. So in this case, we'll perform it for you in a classic sense and then modified. The classic is taught with the upper hand outer. In other words, it's got to control the femur. Lower hand is controlling the tibia. And when the loading is applied, I want to pull directly anteriorly. I don't want to be rotating. And Jared can tell you there's a nice thunk. I think you can see that. The other thing that I do as an examiner, I was very lucky, I was taught this very early on. When I am going to be applying my load anteriorly again, I start posterior
but then as I apply it, I also move the other hand in the opposite direction. Now, in teaching, I think it's better for you to start by just stabilizing. And you can see thunk, 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 beautiful endpoint, okay? But for me, I was always taught to, and Jared would tell you, that magnifies the thunk on the end. It's cleaner, okay? So on the involved extremity, upper hand, this is where you have to be able to use both hands cleanly. And there's significant motion, but no thunk, okay? And again, I start posterior and bring him anteriorly, but there is no thunk. Now, for some of you, you're going to find that hands are smaller, legs are larger. Technique number one is put the knee under, stabilize with one hand, and apply your load with the lower hand. Again, trying to make sure that you keep them not from internally rotated or externally rotated, stay neutral. Likewise, you then would do the same technique, knee under. I'm going to try and stay out of the way as much as I can for you. Same technique. In a clinical sense, if you really wanted to, you could put a bolster under both knees, put a mob strap across, use both hands for doing the loading. In John Fagan's book called The Crucial Ligaments, Dr. Fagan will actually demonstrate a prone Lockman. Now, just for fun, we'll go ahead and go prone for me.
Now you have to then remember, you've got to go to the other side of the body now because this becomes the uninvolved side. And in the prone Lockman, the concept is that you move distally, bring them up a little bit, get them relaxed, and then you're going to apply a load down into the table, if you will.
And I think Jared would tell you, thunk, thunk, thunk is a wonderful endpoint. And when we move to the other extremity, we have very nice movement, but there's no thunk. Now, the negative of using this type of assessment is you have to rely totally on your sensation, and vision cannot be a part. Now, just for fun, go ahead and back up into a... One of the things that we always look for is there significant involvement with the capsule? With the initial injury, one of the concerns always is that you can also start to develop rotational instability. And in Jared's case, the way we would assess that is we start in neutral, we externally rotate a few degrees, repeat the assessment, and he tightens up a little bit with rotation. That's telling me that his capsule on the medial side and his capsule on the lateral side both respond as one would expect. As you internally rotate slightly or externally rotate slightly, those posterior capsular structures should tighten and actually should tighten up a little bit. In an individual who's torn the cruciate, the concern is that over time, particularly, not always with the initial, but over time, they can start to stretch out their capsule. And when that happens, you're stretching a secondary restraint, which then can become a problem in early rehab. You may want to really make sure you protect that individual because sometimes surgeons will purposefully try to tighten up that capsule where it was attenuated. So just for fun, there's what we have. If we externally rotate a little bit, that should tighten up the medial side, and it's a little better. And internally rotate just a few degrees. And so his capsule appears to be intact. Now, We already do know from the MRI that he does have a meniscus as well. And they will not know for certain how much meniscal involvement they have until they are in the surgical suite. So I'm not going to demonstrate any additional types of things because we don't want to flare that up at this point. So anything else you'd like to know, Jared?
I think I'm good.
All right, one of the things that the last few years people have been using a second test that was developed by a physician in Europe. His name is Dr. Lilly. And what Dr. Lilly basically recommends is that we should pay attention to a reverse process. Rather than trying to assess the ligament in a direct format, we can do this in a secondary format. So what I'm going to do first, I'm just going to have him bend this knee up so that what we're going to be watching is down here. And the test is that we put our fist basically several finger breadths below the tibial tuberosity. And then the actual test portion is that all we're going to do is push down above the patella to see if the heel comes off the table. And that is a normal orientation. In a person who has torn their cruciate, we're going to see an abnormal. So in this case, just kind of watch and we'll kind of smile. And as you can see very clearly, we don't get the heel to come off the table. Now, this only works in a percentage of patients. And Dr. Lilly's original work, it's almost a perfect test. Yeah, he's from Italy, and it isn't that perfect. But it is a test that you can use in this format, and you can see in Jared's case, it clearly is positive. Some of the most recent work on this, published in the mid-teens here, basically showed that we're probably looking at 70, maybe 70% of the time this will be a positive test, and we know that the Lockman is a much higher percentage, well over 90%. So the Lockman is preferred the majority of the time.